In this session on implementation science in Latin America, we have 3 speakers. I'll introduce them one at a time. Our first speaker is Dr. Valerie Paz-Soldan. She's a Peruvian American social scientist at the Tulane School of Public Health and Tropical Medicine and the director of the Tulane Health Office for Latin America. She's based permanently in Peru since 2004. For the past 8 years, she's applied implementation science approaches to infectious diseases, including cervical cancer prevention and control. Specifically, she directs the Proyecto Precancer in Peru, an implementation science project for an HPV-based screen and treat program in the rainforest city of Iquitos, Peru, for the prevention and control of cervical cancer. Welcome.
Well, everybody's still eating lunch, but we're going to go ahead and get started. So this project is the dream child of myself, but I need to acknowledge Patty Gravitt, Dr. Patty Gravitt. She was a cervical cancer expert and the brilliant mind who understood the content, and I was the context. I knew Peru, I worked in Peru, I worked in the rainforest, and we came together to make this happen. And this is now the scaling up and adaptation of a project that we started in Iquitos that now is going nationwide with the Ministry of Health. And I'm going to talk specifically about the project that's happening in the river communities in Peru. So, and I present on behalf of our team. How do I move it? Put it there. Right now? Yeah. Okay. So this slide is meant to give you context of the situation in Peru. Of the red dotted line is globally the cervical cancer incidence. The orange line represents women, our sisters in South America, and the blue line shows the cervical cancer incidence in Peru. Despite the fact that the Ministry of Health has said cervical cancer is a priority in Peru since 1998. But it's also used to, when we engaged all our stakeholders, every time we started a meeting, because we were prepared for people saying, no, we're doing okay, we're getting better. So this was often our first slide in every conversation to say, this is where we are, and do you find this acceptable? Because these are women who are dying unnecessarily, so we need to be focused on what do we need to do. So it was kind of our shared vision. We want to change this. And so Patty Gravitt and myself set out to facilitate change. And we did this by asking the question, what is the best public health strategy that is feasible, acceptable, and equitable, considering system challenges? We were working in the city of Iquitos, which you can see in this picture, a city of 400,000 people that can only be reached by boat or by airplane because it's in the middle of the Peruvian rainforest. So talk about lack of oncologists, lack of pathologists, and yet there's a hospital, but we didn't have the right human resources in this location. We also had a culture of stigma. You see the cover of the book that came out right when we were starting our project. Papillomavirus, the virus of the infidelity. So we're dealing with geographic challenges, we're dealing with stigma, we're dealing with lack of the right providers in the system. They were doing Pap smears every year where the Pap sample would be sent to Lima. It would take 3 to 6 months for the result to come back, et cetera, et cetera. So we set out to respond to this question, and we were implementation scientists who didn't really know what we were. We didn't really speak the language yet, but we knew what we wanted to do. We knew the function that we wanted to carry out. And because we didn't know the language at the time, we set out to carry out what we believed needed to happen, which is a function. I'm focusing on your language. It wasn't a model, and we developed our own process model, which looking back was probably very similar to EPIS, but we called it the INSPIRE process model with 4 phases. The first phase being understand the system. Everybody thinks they understand the problem. They think they understand the system, but a lot of times what one person is seen as the problem, another person thinks it's a different problem. So we needed to come together to understand the system and the problem. And this is where we found a lot of fragmentation, duplication, lack of data in the system. They could only tell you how many people got a Pap smear, but had no way of telling us how many women with abnormal Paps got any follow-up. There was just no way to look at that in the system. We needed to find leverage in the system. This is where we came together with stakeholders. We didn't create a parallel system. We created a system that was within the public health system. It took longer because we weren't going to create something that then had to be embedded. We started from the start working with the public health system. And we shared evidence for HPV testing, thermal ablation, the existence of thermocoagulators that could be used because the chemotherapy, the cryotherapy, has to use these big balloons, and the only way to get them was either by boat or airplane. So we had all these different challenges, and we talked about what is the evidence that would be locally feasible and relevant, and test shifting, because we couldn't add more people to the system. And then we worked on strategic planning, where we put together working groups, training, procurement, which is still a problem. Procurement continues to be a problem in Peru, and the learning and adapting, which is basically another way to say monitoring and evaluation of the data, figure out where the loss to follow-up is still happening, what are the gaps, how do we address stigma, and how do we compare rural to urban, different challenges, different contexts. And again, the underlying mechanisms that we were looking at. And so several people today have spoken about the mechanisms. So we did a realist evaluation to figure out what are the mechanisms that are making this function. And our tools, which are participatory action research, systems thinking. This is not just a discrete, it's a multifaceted, I just learned that word. It's a multifaceted implementation. Process mapping, making the data visual, making the data make sense for the users. Facilitation, which seems obvious, except in a hierarchical system where people often tell others what to do, using facilitation to engage and empower and create ownership of what we decided to do was new. Long-term engagement, we didn't go once and leave. I live in Peru. I go to the rainforest every 2 or 3 months. I stay there for 10 days. And then as we started learning the language of implementation science, starting to see how our data fit into these models like CIFR. And we published our Inspire model as well as how we made it happen. And one of the key things that we learned in that first phase, where we started working with implementation science in Iquitos, was the importance of collaboration. So, and the key stakeholders, right? We wanted to make sure we had a true collaboration partnership and work together to figure out what was going to work for their system. And what they came up with us as partners, was the importance of simplifying the system and moving more to the primary level, because the hospital was a huge bottleneck. And so the model that you're seeing in front of you, the mental model, shows what we move towards. We move towards a target population, getting HPV testing with cell sampling or at the clinic, being eligible for ablative, if you're positive, if you have HPV, getting a visual assessment for treatment at the primary level. If you're eligible for it, get the treatment at that primary level, and only if you have lesions or suspicious of cancer that you got moved on. So that was the mental model, and you see what happened. We tripled screening within months. COVID then hit, and then we again rose above the monthly screening goals we needed. COVID then hit again, and then we had a procurement issue that took us all down. And we also almost tripled care completion, where we saw that by moving it to the primary level, we were able to give care to more of the women. And there you see me at one of the hospitals, which continues to be a problem. That's where we continue to have loss to follow-up, but that's the second largest hospital in Iquitos. We saw a big improvement in rural areas. If you look at the first, you see pre-implementation and post-implementation in the urban areas, there was an increase. But look at the increase in the screening by self-sampling, but in screening in peri-urban and rural areas. That's where we really had an impact, because all of a sudden we were bringing HPV self-sampling to places where they normally weren't accessing health facilities. But was this enough? And this is the point of my talk today. Was this enough? Is there equity? If you look at the graph at the bottom right, the biggest cervical cancer mortality is occurring in the jungles of Peru. 2/3 of Peru's territory is jungle, is a rainforest. In Iquitos, that red zone, the largest state in our country, there's only one freeway from Iquitos to Nauta, up in the middle. That's it. The only other way to move around this state is by boat, or maybe by a small airplane, but that's the only way. So did we create a system that's equitable, or did once again we create a system that worked in this city? And how did we make sure that we could help to increase equity? And that is when we focus on the equitable part, the adaptation and scale up for equity. And how do we make sure we're reaching every woman, especially the ones who most need it? We found a program that has this ships that take healthcare. They have some labs, basic primary care, prenatal care. And it's called the Programa Itinerante de Atención de Salud. And these are the different ways. They have it by ship or by airplane, as the bottom picture shows. And these ships go along Amazon rivers and the tributaries of the Amazon. And you see that they have their lab. So what did we do? Learning about the mechanisms we use in the first phase, we now set it up on these ships. We set up Gene Expert on these boats. We trained lab personnel, how to maintain the machines, how to make them work, how to run samples. We then trained personnel, but we didn't train them. The personnel we had trained in Iquitos trained the personnel on these ships. And in fact, some of them were the ones that were hired to go on the ships. And they trained them on HPV, on counseling on HPV, on counseling on results, and how to do self-sampling, because that's what they were going to do in these river communities. We ensured that there was data that was being collected and systematized. And 3 ships have already gone out. And in that time, we went from where they would do 6 or 7 pap smears in the time that they were out on the river to now we were doing about 70 or 80 HPV testing. Those 6 pap smears they were doing in the past, women would never get their result. They would never get a follow-up because the ship might come back in 9 months or in a year. So it was almost like unneeded. Whereas now, of the 233 women who we screened in the last 3 ships that have gone out, 35 were HPV positive for 15%. And out of these 35, 32 were able to receive visual assessment for treatment on the ship and ablative therapy on the spot. So we got to the river community, we assessed them, we did the sample, we assessed for treatment, and did the ablative therapy. We still have missed 3. One of them was suspicious of cancer, and we needed to get her to the hospital. One of them returned to her community, and unfortunately, she was on the border with Colombia, so she returned to Colombia, and we weren't able to give her her result. And one had a partner who rejected treatment, so she had gone back home, came back for treatment the next day, and the partner had said, no, they're not touching you. So that also taught us a lesson, which is the importance of quick treatment on the spot for women who want it. And the evidence for us of sustainability and scale up is that the Peruvian National Director for the PS programs just 2 weeks ago came to Iquitos and saw this in action and now wants to scale up this approach throughout the Peruvian Amazon region. We also have evidence that some other programs like the tuberculosis program is interested in maybe using these gene experts to test people for tuberculosis, not only just HPV. So we're seeing a scale up that's horizontal, but also vertical into other diseases and illnesses. And I just want to end by saying equity requires innovative strategies that bring screening and treatment to the most vulnerable people, and using implementation science methods for adaptation and scale up if we hope to eliminate cervical cancer. And otherwise, we really can't be talking about elimination if we can't get to the most vulnerable. And I also want to say, if you want to go far, if you want to go fast, go alone. But if you want to go far, we really need to work together to take everyone along in this path. And I can't end without saying this is really a large collaboration, and the stakeholder group are really now good friends, but it's been a whole group effort. So I want to thank everyone involved in this.